world where communication is a growing industry, communication is often still not clear and constructive. The PTCMA addresses this by providing a neutral platform, connecting players in the healthcare industry and equipping them to speak the same language, effectively reading off the same page for better industry relationships and optimal patient care. We do this through virtual CPD webinars, online courses, and in-person networking and education events. Contact us for more information on our programs and member benefits.
Hi, good morning everybody, and welcome to our HTA slot. My name is Donata Gubega. I come from Medtronic, and I'm the board member for SAMED. I'll give you a bit of history so that you understand why I fit in the HTA. So I have a three-angle experience. I worked in the hospitals. I could see the struggles with HTA from the hospital side. I moved to the funders. I spent all my life with Discovery Health. I see most of my former bosses and colleagues here. And then I moved to the MedTech. I worked with Johnson & Johnson, and now I'm with Medtronic. So HTA has been a bone that has been very hard to chew. But before we go there, I'd like to introduce my panel. So I'll start with Dr. Gary Kantor, if you can join me on stage. Followed by Wesley Solomons. Debjani is on the computer. She will be joining us online. And then we have a short change. Lerato Musia will be replaced by Dr. Noluthando, who is a little bit held up in an interview outside, but she will be joining the panel soon. Okay, let me take a seat. So I'm going to ask my panel to introduce themselves in fully, where they fit in the whole structure of HTA, so that it will be easier for us to understand who to ask questions. And with that, I have also asked my panelists that we won't read a script, or I won't give them time to go through so many discussions. I'd like this to be an interactive session where everybody's here. I can see a lot of people would like to ask questions, from market access to everybody in the medtech, to the doctors, to the CEOs who can ask questions that have been lingering over some time, and we have the great panelists here. So with that, I'll just ask my panelists to start giving us their background. Dr. Gary, I'll start with you.
Good morning, everyone. I too have a little bit of a trajectory through the healthcare industry. I'm an anesthesiologist by trade, so spent more than a couple of decades as a clinician. I pretty soon got interested in systems as a whole, and quality as a concept, and improvement, all of which requires sort of a system-level viewpoint on how to get better outcomes. I then spent a number of years at Discovery also, in the risk intelligence group, and then actually spent some time with Noluthando's unit, learning HTA. And so I have, a number of different perspectives on technology as a user, in terms of how things get implemented and the outcomes they might achieve.
Thank you.
So I do have a slide which sort of sets a context for our discussion that actually comes from Noluthando's article. So we can put that up quickly, and that just shows the complexity of the system we're talking about, with a number of role players all trying to use technology, develop technology, appraise technology, and ultimately get better outcomes. And I guess one of the questions, broadly speaking, is the topic for today about an agency is maybe a much more complex question with complex answers coming out of a complex system, but we may attempt to simplify. I'll stop there.
Okay, so before we give him a chance to go through the slide, I'd like to introduce Dr. Noluthando. She's just being mic'd out, so she'll be joining us on stage. While she's doing that, I'll move over to Wesley to introduce yourself.
Should have said I must go first. I don't have a pedigree like you. I'm at National Department of Health. It's time for my time in purgatory. And over there, I'm actually an epidemiologist by trade. Sorry, did I miss something? I'm an epidemiologist by trade and a technology enthusiast. So I was the first person to introduce mobile health applications in a real-life setting. The time we used to use phones that could take a battery out of. And we became the largest intervention in the world and in South Africa through the Good Start project, and actually led to the dual therapy application of... please come. Please sit in the middle. So dual therapy application of PMTCT. So I saw the impact of digital interventions improving healthcare in real things. Welcome. And so I've also worked, I'm currently at NDOH at the innovation unit, the digital innovation unit, looking at NHI. And I'm here with my colleague Kevin, who is charging his phone. Kevin, are you still there? And what we're doing over there is we're looking at ways in pragmatism of how does we support the value system of NHI through a digital health system. And it is, just like your slide, incredibly complex and taking baby steps along the way. One of the aspects that are most important is governance and how we come to decisions and an inclusive governance. And this is where HTA fits into it. And so I would love to engage in conversations with this to say, how do we have a real view of HTA for the country that takes it forward? Just to premise it, two very big opening statements. Number one, as a country, as an industry, both private, I'm being provocative, both private and public sector, especially public sector, we're struggling to have the divide between pharma and medical devices. And I'm talking the broad spectrum. It's a difficult divide to get your head around regulating and having governance on. So I'm premising that. But the solution of it is, once you start taking a patient-centric view of things and saying, how do we benefit healthcare? This divide starts making a lot more sense. So that's just premising it up front, and I'll stop there. Thank you.
Okay. Thank you. So before we jump the queue, because Dr. Nolu came late, we'll just go to Dr. Debjani to introduce herself. Yes. I think you're on mute or your sound is very far.
Good morning, everyone. You can hear me now, right?
Yes, yes.
Okay. So sorry, it's a pity that I can't be there, but yeah, let's go along with it. My background is in engineering and moved into the field of health technology assessment. And mostly my work is in research and academic side and also in the public sector. So in my opinion, HTA is just a tool, but we are there to assist with this application of this tool for better health outcomes for the patient. So from there, let's take it forward. Thank you.
Thank you. So I'll move over to Dr. Nolu. First, I want to thank her very much. She had to fit in the slot. She was not part of the slot, so I negotiated for her to be here. So we appreciate your time. And with that, I'll hand over to you to introduce yourself.
Okay, thank you so much for inviting me to this panel. So I apologize in advance because I'm doing the second panel as well. If people get tired of this face, just sorry in advance. So thank you so much. My name is Noluthando Nematswerani. I currently head the Center for Clinical Excellence at Discovery. The unit is actually responsible for health technology assessments. We do clinical policy development, medicine strategy. We look after the broader surgical risk management. I think we engage with most people move from the companies that are represented here in terms of the PIN process and just overall, management of our medical devices. So I'm a medical doctor by training. I've been at Discovery for many, many years. And I think I'm bringing, obviously, a perspective from the private healthcare environment and in the medical scheme space where I work for the administrator, and we are tasked by the schemes that we administer to manage the risk for the schemes. And I think we've used a health technology assessment as a tool to actually try and allocate funding in a responsible and more sustainable manner for the schemes. So really that's the perspective I'm bringing today.
Thank you so much. With that, we'll start with a presentation from Dr. Gary. And then after the presentation, I'd like the audience to please fully participate. I'm sure you all have so many questions that you'd like to ask this panel. And some of you may never meet this panel again in person. So I thought let's do it as a very open and dynamic session. So we'll take over to the video, to the presentation, and then from there we'll start with the questions.
So we're waiting for the video to come?
Yeah. Who's switching on the video? Okay. All right, over to you.
Okay. All right. I certainly don't mean this to be a lecture, and rather when I was gathering my thoughts for this panel, I decided I'd try to organize my thinking, and I have just a framework for the discussion today, hopefully, which is on the next slide. Before I do that, I should have said, no longer with Discovery, I work with Insight Actuaries and Consultants, who are an independent group of actuaries, data scientists, who interact with the healthcare system, not only in terms of schemes, but also professional groups and hospital groups. So it's kind of in the middle of all of that. So if we're going to talk about HTA, I think it's what it's used for ultimately, which is decision making, what gets funded, what gets supported, and ultimately what gets used and implemented. And then I think maybe the missing piece in all of this is the downstream evaluation. So when medical schemes or provincial departments of health pick technologies and fund those technologies, what are the outcomes we're getting? And how do those outcomes feed back into the HTA decision-making and evaluation process? So I think that's a framework for the discussion, potentially. And just to flesh that out a tiny bit, obviously the HTA is safety, efficacy, and affordability. The decision-making brings in a social perspective, a societal perspective, sustainability we heard about this morning, equity, which is what I think the bottom line is for the whole NHI enterprise. And then it needs to include multiple stakeholders, including, I think, primarily citizens themselves, often missing from the debate. And then the implementation, clearly once technology gets approved, people and processes are the things that make it happen to deliver the outcomes that we would wish for an NHI or any healthcare system. And those outcomes are clinical, they're cost, but there are two, I think, missing ingredients here, which are patient-reported outcomes and actually the outcomes experienced by the healthcare workforce implementing those technologies. And then the feedback loop, I think, is data, but it's also conversations, rich conversations to make better decisions. And then my bullet points that I was going to offer for today are, what are the aims of the NHI? I've already said I think it's primarily about equity, but quality and equity. And then the context you've already seen from the first slide is many, many entities involved in HTA, two parallel healthcare systems, resource limitations, which are a lot on the human resource side, and existing policy and legal frameworks which create path dependence. We need lots more research and evidence, I think, to drive the system forward and get better outcomes. An HTA agency, if there is to be one, or the HTA entities, such as they are, need independence from conflicts of interest. and there need to be priority settings across our healthcare system. So Brian just said to me, there's no one in charge of the healthcare system, and that may be true. So I think, why is that? Managerial failures, I think, regulatory issues, particularly on the private side. And we need to overcome those before we get to the specific technology issues and debates. And I think the bottom line for me is we big bang approaches seldom work. I think we need incremental progress, and maybe we can talk about some of the ways to make small steps towards better HTA and better outcomes for the healthcare system population. Enough from me.
Thank you. Thanks for the insightfulness. So I happen to have been on the other side with Dr. Nolu, the late Dr. Vesna, and I have interacted with most of you. Some of you, they know me from trying to just educate you on how to bring along your HTAs for reviews, how to simplify it, etc. So I know both ends. I'm now on this side speaking on behalf of the MedTech, and I know your struggles. I'm in the same struggle. But we want to unpack it. So I know one of the areas that we're concentrating on is that we would like to see South Africa with an HTA agency, not a discovery, not any other scheme or a public health one, but one HTA agency that caters for everybody. And with that, I'd like to start off and just open the floor for questions that you'd like to ask my panel here. If you'd like, you can say the name. I want to ask Dr. Nolu, but please don't ask Dr. Nolu only, because I think she's the one who's with the funders. We've got NHI there, so we've got data, we've got Dr. Debjani, who's mostly in the educational space. So I'll kick off with the questions before I can go through some of the questions here. Anybody who'd like to break the ice and start with a question? I've got one here.
Thank you. Do I have to introduce myself?
Yeah, it's
I'm Bulalo Maponya, Head of Market Access at Boston Scientific. Thank you, Donata, and the team up there. There is definitely going to be lots of questions. And I have no doubt that Market Access managers, they've got questions for you guys. So it's going to be a very hot moment. The first question I have is to all of you. What does an appropriate and sustainable health technology assessment agency look like for South Africa, in your view? And I would love to have a response, if possible, from all of you.
okay. We can start with Dr. Gary.
Yeah. This was one of the questions that was sort of given to us ahead of time. And I think a few things. As I said, I'm not sure about a single agency, and leapfrogging to that. We don't have a good history in that regard. But I think we should talk about using all the available expertise fully, and that diagram suggests there's lots in the system, but we need to grow that capacity over time. I think we need collaboration internally and with international agencies. That already exists, I think, in an informal way. I think we need collaboration between public and private. We need freedom from conflicts of interest. We need speed. So if you're at NICE in the UK, typical HTA takes 18 months. It's a lot quicker in Noluthando's group, and it needs to be. It needs to be accountable, so it has to have its performance measured in some way, and I'm not sure what that would be. Throughput, but quality in some kind. And reasonable confidence levels, in the capabilities of, this collaboration and its outputs, if we're going to rely on it collectively. So, and I think couple more bullet points is, encouraging technology investment and capability locally. So I think that needs to be sort of built in, some kind of favoring of local capacity building. We've already seen during the pandemic how critical that is, and we've talked about it already this morning. And then finally, I think Universities may have a leadership role in all of this as a place that's got relative independence from conflicts of interest, which I think is a key aspect of any kind of collaboration and agency where we share the results and use the results of the technology assessment for decision making.
Thank you. The one point that I'll add there on behalf of the industry is that sometimes the industry feels like HTA is used as an obstacle to get our new technologies through. However, the expectations from the funder, the payers, it's more like there's money involved, there's technology, there are no clinical studies. Medical devices don't have randomized clinical studies immediately. So there's always an obstacle. But with that, I'll move over to Dr. Nolu.
Thank you so much, and thank you for the question. I'm not personally at the level where I'm seeing one single HTA agency for South Africa, considering obviously the roles that the private sector and the public sector play. I do think South Africa does need a health technology assessment agency like other countries. If you think about the NICE in the UK. But when you think about a body like that, for it to be sustainable, there are various factors, obviously, that will make sure that it is sustainable. It's really about, I think right now we are actually needing to resource it. So in terms of funding, the human resources that are going to be managing that agency, just the skills to actually do HTAs. Right now we are very short on skills in terms of doing HTAs. For me, the reason why I don't see us having one single HTA is because of priorities. If you think about what the output of that HTA assessment is going to look like, how do you prioritize certain products, if you've got one single agent? If you look at what the private sector currently funds, we fund way more than what the public sector funds. So there may be issues around prioritization. And if you think about NHI and the way it's currently structured, if the private sector is going to be only, offering complementary services, what happens then in terms of priorities? So there will be misalignment in terms of priorities. So I think for me, it's a great, initiative to actually have one HTA body for the country to actually service the population of South Africa. But when you think about, the two sectors, there may be a challenge in terms of trying to merge the two. There will always be a requirement for private entities to do their own HTAs. We see it in other countries where the private entities still do their own HTA because you need to prioritize for your needs and make sure that there is, because for the medtech companies, all you are needing is for funders to fund your products. That's really that. You're looking for access. So the quicker you can get your devices evaluated, the quicker you can get a decision around funding. And I think for me, if there are those conflicting priorities, because you may be coming with state-of-the-art equipment that the public sector is not looking at the time, because the needs are such that they will need to prioritize some other basic interventions that are on the queue. So it's just thinking about what that means from an access point of view, because there may be delays in getting your products into the market and, in fact, funded. And I think which is why we see, for example, when you think about the NICE process, if it takes 18 months for a full health technology assessment to be completed, then you are going to wait that long. And remember, once it's done, it doesn't mean that you get funding immediately. There's still a process in terms of getting negotiations, until, and remember they hand over. Whereas if you look at our process within Discovery, we do the full end-to-end process where you do the HTA, we do the negotiation, we do the implementation of funding. So I think for me, for now, I think the two systems still have different priorities in terms of what we are looking for and what we are funding, and a single HTA agency may not necessarily work. If we're looking at a private agency, which the Council for Medical Scheme was recommending in the interim while we wait for the bigger, single HTA agency. Even in that space, you do need to prioritize, because different administrators may prioritize different products because of the demands from their membership. If you've got a scheme that has got mainly elderly patients, you may want to prioritize specific interventions because that's what's important for your membership. So it's all those factors, but then there's the broader issue around setting it up, the governance structures, the funding, the skills to actually contribute to that agency.
I think just to wrap on that point would be, I'm sure in the audience there will be people who will say, I'll be interested to participate or include the medtech when this agent is being designed, so that at least the needs for the medtech are also met in a way so that we understand, because like we have discussed this with you before, there are HTA proper, there are many HTAs, so such things I think the industry would need to be included when we start designing such a space. And with that, I'll skip you a bit. I'll have you last. I'll go to Dr. Debjani and ask her if she's got any comments.
I'll turn off my camera because there is sometimes repetitions. So yeah, when you, it's not possible with the technologies available and the needs in the country to have a single entity from one day to the next, right? So you need the resources, both financial and human resources, and that, as mentioned, is not available. And the needs may be varied between the national, the regional, or at the hospital level. And we have seen in other countries, like when you think about Italy, Canada, or in the South Americas, there are different ways to mitigate this issue, and through a network of experts, through different HTAs at hospitals or at the regional level or the provincial level, like in Spain. So there are many ways to, many models to mitigate this issue. And also, as also mentioned, the priorities, may be different in the different, depending upon the population, and that needs to be taken care of. And it shouldn't be just, when we're talking drugs or devices or whatever, but, a holistic view. So for now, that's all. Thank you.
Okay, thank you. And then I'll move over to Wesley. And because of time, I want us to have a little bit more questions. Maybe for the next question, I'll just ask one panelist to answer so that we get a little bit of more questions going on. Do you want to just wrap it up in?
Oh, sorry, I forgot the question again. What was it? What would the HTA agency look?
Yes.
Okay, thank you. Sorry, my attention span is low. What I think is going to start with is something that I was in charge of in terms of clinical coding in South Africa and getting a structure together to have a harmonized view of clinical coding. And Tanya was involved with it. A couple of lessons learned, and I'll take this to where HTA agency is going, is that the expertise really needed to evaluate which coding structures are necessary or useful to be unified, or at least standards agreed upon, does not sit in one room. We had in excess of 149 contributors, and not just piecemeal contributors, like physically people phoning, screaming at me 11 o'clock at night to tell me how stupid I am, that their point is across. And you know how helpful that was. Where we eventually landed with the coding was saying, the big bang approach doesn't work. So I would like to agree with you with that completely. And so we're taking it step for step for step. And one of the reasons why I'm here at this conference is because afterwards we went down a rabbit hole of medical devices and coding standards for them and realized, whoa, this is a major rabbit hole. We cannot make a resolution on this. It's going to require more people, more time. Now, bearing that in mind, we are on a trajectory, and we managed to do in 10 weeks, which the WHO has now commended us to say that countries have not done in 20 years, reaching agreement. And the reason we did that was multiple stakeholders across industry, public, private, taking the hat off with a shared vision. We need to make this work. So for 10 weeks, there's a whole team going back to WHO because they don't believe us, and in Geneva in October. I'm not going because they can go and talk. But on that note, the same process has been asked of us now to set up for HTA agencies, knowing that it's not going to be tomorrow, it's not going to be in 2 years, it's not going to be in 5 years, but we have to take that first step. And the first step is, and I finished the submission last week, we are going to invite industry to the table. That's the first thing. We have Janine. What's Janine's surname? I forgot her name. I can't say her surname. I'll ask Tanya. She's been allocated as the person to lead this at National Department of Health, and it's going to be hard work to get this together. Now, the lessons learned from the coding is what I'm going to actually answer in terms of the questions for what an agency would look like. The first thing is, the HTA agency's role is not to approve or to say, you suck, you can't do your device. It cannot be binary. We need to think of an HTA agency as fostering innovation. So let's just say you do not pass your HTA assessment in terms of cost. It's too expensive to take its scale. Or there is a safety issue. Oops, you can't go into this. There's many facets to it. How is this HTA agency going to say, you know what, how do we foster this innovation? Because the truth is that medical device technologies are absolute disruptors to industry. Now, if you take that out of the equation and say, we're just going to say, okay, it's fine, we're going to fund this is going to do well for patients, it can physically change clinical guidelines. I mean, how fundamental is that? There's not many things in this world that we can actually say, if you introduce this, then you are going to change the clinical guidelines. I looked up the thermometer, and this is what our industry, in terms of National Department of Health, is geared up to doing. The first thermometer we agree it's now commonplace, was out in the 1700s. It took another 100 years to make the next leap, so 1800s. I won't be around in 100 years' time to see technologies. And the next 100 years, 1900s, is when you started thinking about the infrared thermometer. Only in 1912, whatever, Titanic time, is when the infrared thermometer started being created, and now we have a touchless technology going forward. We don't have 100 years to wait for technology to innovate. We're talking about something that could fundamentally change the health of a person tomorrow if it can get into industry quickly. So the role of an HTA agency must have this in mind. We're not going to regulate and just look at X, Y, and Z. There needs to be a cluster for innovation and rapid innovation. And that's one of the recommendations that we are thinking through. Not only in device technology, but also for innovative pharma. Same thing. So the way we're looking at doing it is fundamentally different. The last factor I want to put in is that the level of expertise. Who is going to evaluate this? It's not sitting at National Department of Health. If you're bringing in a technology that's using nuclear medicine, I'm going to have to bring someone in from Chernobyl to come and help me with that or something like that, you know? It's not going to be the expertise over here. So the agency would be like a governance umbrella sitting over there, but for particular bespoke needs, there has to be a group of expertise that are looking at these needs and evaluating it in rapid time. Because that's how we're going to force multiply any sort of intervention. Because 6 months down the line, it's old technology. It's done. And so, yeah, I think I'll pause there for that moment.
Thank you. I'm glad you said that, because the medical devices, that's the problem we have. Our products, they get innovated, and we keep knocking for approvals. You find that while the one is being innovated, the one is still not approved. So we just need to see how we work around that. So I've got a few questions, and I'll ask the panelists to take the question that they feel they are strongly to answer that, so that we just move the time. So I see Brian, I see there's one there.
Good morning, everybody. Amanda from Umsinzi. I moved here 15 years ago from UK, and I was actually involved for the first 5 years in the setup of NICE. Back in the UK before I moved here, but from an industry perspective, if that makes sense, and from a medical devices perspective. So I think a combination of Gary's comment about the rich conversations, and then Wesley bringing in the notion of being a place that fosters innovation and the best possible care for patients, with the patient at the centre of everything, is vital. But I do think there's an amazing opportunity to learn from others not so great examples. Do you know what I mean? There's a reason why NICE takes as long as it does, because it's stuck effectively in a rut. in terms of perhaps thinking that it has to do everything. So to Wesley's point, this notion of turning it on its head and coming at it from a different approach, I think is a really, really good one, because devices by definition are not medicines. They're not medicines unless it's a drug delivery device. So really it is about taking those differences, I think, but I think also from an HTA perspective, take the opportunity as well to learn from when it has not gone so well previously in other countries as well. I think there are probably more examples of what not to do than what to do well that we could learn from, we could really learn from. But I love, Wesley, your thought of turning it on its head. It reminds me more of downwind sailing than upwind sailing, if that makes sense. That it's adaptive and it actually puts the patient first and foremost. Thank you.
Thank you. So Brian's hand before we respond to that.
I was going to ask the question that Amanda's just answered, which is, Wesley, are you looking at government-to-government discussions about giving us something of a head start by understanding, and not just NICE, but I guess the Australians have agencies, and a lot of the technologies, presumably there's a lot of really useful evaluation that's done. We don't necessarily have to reinvent the wheel.
Yeah. So I was sort of stressing a bit because intergovernment discussions don't go very well in this country. But government to government, standing on the shoulders of giants, absolutely. One of the comments that you made earlier was when you said about conflict of interest and mitigating conflict of interest and the role of universities, I think. It's one of the factors we're doing with coding is we're actually saying, you know what? The higher education institutions are experts at looking at this and digging into where we can leapfrog and stuff. Why do we mandate them to do this and come back to us and say, these are the recommendations, show us who you've consulted? And similarly with regards to leapfrogging with HTA assessment and different paradigms or structures, let's research, let's not stand at things, let's get something that's very nice, not just nice. And let's work in that factor. And the notion that we have in this, that we have really independent players with no conflict of interest. I mean, this is such an incestuous pool. But the principles of NHI is the referee cannot be the player, cannot be the regulator. That's the principle of it. And if we conflate HTA and you mix any of those factors, it's a recipe for disaster. So, yeah, thank you.
Can I just say something around other countries? I think if you look at HTA agencies in other countries, I think they've done very well with pharmaceuticals.
Yeah.
And I think that is well established. And I mean, the clinical data for pharmaceuticals is also at a different level to medtechs. I think even other countries, I mean, they are starting even with NICE. They didn't have a focus on medical devices, and as a result, you see even their evaluations. You can see the difference between an evaluation that they've done for a medical technology versus what they've done for a pharmaceutical agent. So I think the world is also learning, because there was a time when medical devices were actually not evaluated until we saw harms, patient harms. And then there was, it was almost like a wake-up call to say, actually, we've been too lenient here. But now the issue is that if you move too much to the other end, where you're saying, here is an established process for pharmaceutical companies, they have got well-established clinical data that allows that HTA process to move quickly. And more, I mean, there isn't much in terms of questioning the data. You can just interrogate, obviously, the study design and everything else and the outcomes of the study. But the structure in terms of study design is already there. With medtechs, it's really a different story altogether, because, like Donata is saying, randomized controlled trials for medical devices may not necessarily always be appropriate. So it's all of those things. And I think for us, when we talk HTA, we need to just think about HTA is not just, it's not one bag of everything. When you look at medical devices, you have to take into account some of the limitations and look at ways to mitigate so that you can still make a reasonable assessment of that medical device. And I think those are some of the challenges that, our team has been facing. And I think while the industry may feel that health technology assessments are almost a barrier to access, it's actually also a safety tool for patients.
Yeah, but I'd like you to unpack this a little bit further, maybe during lunch break, because we might be running out of time, but that's what the industry would like to know. Dr. Debjani, please raise your hand, because we speaking here and there. I'll take one question from Mark. Caroline, will you time me? I didn't bring my timer, so you let me know how we're doing for time. Mark, I'll hand over to you. She will respond to your question.
Thank you very much, and I cannot disagree with most of which the panelists have said. I think there are three cornerstones to a successful HTA, and particularly delivering the goods, and that is independence, transparency, and accountability. All that has been said. I think beyond that, we have to be inclusive. There has to be it's a multi-stakeholder approach, whichever way you look at it. I want to back up a bit, and at risk of showing my age, this is not a new discussion. This started in the last century, dare I say it. We had lengthy discussions, actually facilitated and driven by the department, on health technology assessment and what it could and should look like. We had a very representative multi-stakeholder group and audience participating in the process. There was, in fact, a draft proposal for the establishment of HTA in South Africa in 2004. Sadly, with the political changes, and not government changes, but heads of government at the time, with those changes, that all fell apart. And there was some really, really good stuff, really good engagement, really good contributions. And I have to support Gary's comments with respect to the capacity that does exist. Yes, we have a long way to go with respect to building capacity on demand, but the capacity does exist. So I have a personal opinion about what an HTA agency could look like. Not an agency per se, but maybe a coordinating office of all of those skills. They reside, it gives massive potential for expanding capacity within the university environment that offers independence, et cetera, et cetera. But beyond just the HTA component, let me break out two of the process elements, being in the appraisal and the assessment of the data and the evidence. Beyond that is actually prior to that, you have the topic selection and prioritization, and then downstream you have the implementation methodologies, all of which involved all stakeholders. And with that, that's the only way we're going to achieve the three cornerstones of HTA, being independence, transparency, and accountability. Thanks.
I think on your comments is what I've just commented, that at some point we need to have that body, that engagement where the MedTech and this panel of experts can sit together and brainstorm what could work, what should work. I don't know, Dr. Debjani, do you want to say something?
Yes, thank you. Just a comment on the Australian system or any other system, there are learnings from the system, but what we are currently, working on is also looking or adapting the HTA reports as such, because it may not fit to our own context, and how, what are the various ways to solve that issue. But and the other area that I wanted to just bring together is that the assessment as such and the appraisal, for the sake of the transparency, and they are should be completely separate, and then that can bring in different experts when it comes to the assessment, or when you think about the whole life cycle of the assessment process, then there are ways to also engage with the patient or with the citizens or different stakeholders like the manufacturers into the process. So there are different mechanisms to do that. Thank you.
Thank you. Just to add on one point, and I hope the audience still have questions. One thing that used to happen when I was still on the other side of Discovery, I'm glad the three of us come from the same world, but we are former, is that Discovery at some point used to support us with data. I know this is bundle on its own. They used to, before Quantium, it used to be easy to say, I've got this HTA, Discovery will say, we'll run the claims data, we'll show you the experience currently, so it makes it easier for your submission to be looked at using the localized data. And you could say, okay, for this one, maybe it won't fit because of 1, 2, 3. I know that has become a struggle because when we submit, then Discovery doesn't share the same data as they used to do. I know the processes have changed. But I know this is a big struggle for us, the data. How could you make it simpler, or you or Dr. Gary can maybe respond to that?
Yeah, I'm happy to do that. I think that's a good launching point for actually making some progress, because we hopefully can step out of this room and have a couple of ideas of somewhere to start. And I think registries are a key tool for all of this, particularly for technology, because of the difficulty, as we've already said, of doing RCTs. So could one somehow establish, I know there have been many attempts to do so by Discovery with professional groups. Some of them have a bit of longevity. Think of TAVI, we were talking about it during the break. I think we need more of that perhaps doesn't have a commercial quantum cost attached to it, that could be open, that universities perhaps could be the custodians of. That might be a place to start, and just to pick 1 or 2 priority areas to try to learn how to do that in a collective way and become the coordinating office for something, if not the grand agency that's going to solve all problems. And then, and even within the sort of the public-private divide, I think the resolution to that, Wesley and others, is still measurement, because, I think Nolu is skeptical on the whole quali and daily, story, but there are measures, there's ways to score technologies. Qualis are difficult to use, but I think we need some kind of measurement that would help with prioritization for within the public sector, which clearly doesn't have the resources that the private sector does, and to allocate technologies, based on that reality for now. So I think measurement, we come back to measurement. I think we come back to data to support this, and the conversations around it in a place of safety.
So before Dr. Nolu answer on that, I've had a few questions, but I think most of the people here have struggled with HTA, and I don't see that coming out in terms of, let's get it out of them. Let's see what the struggles that you are facing every day when you submit HTA. What are those, and how can they simplify it for you? Especially, Dr. Nolu, I know you are the only funder sitting here. There's no med scheme or others. So 5 minutes. Okay, apparently I'm left with 5 minutes. But can I throw it out to see who's brave enough to ask? I see the market access people sitting here. They're saying nothing. Tanya, you're not the market access. I'm looking for the market access people.
Well, maybe I'm more brave to say it on their behalf. But what I often hear from our members is that HTA, or the schemes, reimbursement methodologies and processes, are a barrier, and they are difficult to navigate. And I think we've done a lot of work with Discovery. We've really collaborated, and we've had a good relationship, reviewing your processes, giving inputs. You've taken that on board, which is really awesome. You've done workshops. You share regularly with our members. And we're trying to kind of reduce that divide and create more understanding. But I think there is still a sense that it is difficult, it's onerous, it's resource intensive, and sometimes there seems to be too much of a focus on the price of the device and not necessarily the value that it brings. So yeah, I could be wrong, but I think that's just what I hear from members. And I think that we need to work on that. There's got to be more trust. We've got to have a common goal in mind. And if we have an HTA agency for South Africa, there must be a common goal that we all buy into. And one other thing that we need to consider is that it will be impossible to do an HTA on all medtech products. There are over 500,000 in the market in South Africa, with 1,000 new ones coming into the market every month. That's the number of NAPI codes that are being applied for every month. So we're going to have to think carefully how we manage this without actually it becoming a barrier, because it's too difficult to get into the market because you have to go through an HTA process for every medtech product.
Thanks, Tanya. I'm sure, unfortunately, the time has run out. Buli has got one, but I'd like my panel to have some closing punches, especially Dr. Nelu. I can see she's...
I have to respond to Tanya and to your data question. So maybe let me start with Tanya's comment. Firstly, we cannot do HTAs for every medical device, which is why we've got two processes. We've got the PIN process, where it's what we call a me too. If it's not a new device, it's just you are launching a product that is similar to whatever is already in place. There's a process to adjudicate over those. And then we look at pricing and we do price benchmarking for those. And it's not a difficult process. But if you make claims that your product has got specific characteristics that make it superior to what we currently are funding, you have to prove that with clinical data. There is no other way. So you cannot say your product is better than the others without showing and proving to us how. And it's not true that we're looking at price. If you're coming and you're making a claim and you add 100,000 to say, for my claim, it's going to be 100,000 more than what you are funding, we have to justify that additional cost by looking at the value that your product brings. And unfortunately, when we evaluate, we cannot get to that point. And sometimes the data is so weak. And I mean, it's a pity we cannot come and show you some of the stuff that we get. And then we'll put the data up there so that you can help us to adjudicate on the clinical data that we get, to say, if it were you looking at this, considering the standard of care, and this is the price tag, and this is the value that is supposedly going to, because it cannot be just supposedly. There must be clinical data that says, if you use my product, this is what happens. We get some very good submissions, by the way, where there is no problem, because the data is there, you can see the value, and the price is matching the value. Unfortunately, most of the submissions, it's more price, less benefit.
Okay, because we have run out of time.
And data, data. Gary, registries apply when, you're already using the technology and you're measuring outcomes and all of that. What Donata is talking about is when they are bringing a new technology and they are looking for clinical data to understand, how it's going to, when they are calculating budget impact and all of that stuff. We do that for ourselves when we make the decisions. But this is after we have completed the clinical evaluation. So we have limited resources at Discovery. We do not have analysts that are just sitting and waiting for these requests. That's the limitation, to be fair. And Quantium, where you want that in-depth analysis around outcomes and all of that, they are, the company to go to for that type of data.
Unfortunately, those people are killing me with time. And I did say to Tanya, this topic will take longer than the time allocated. So I suggest to SAMED that maybe we have half a day where we workshop and we have proper discussion around this. People still want to understand about the NHI and how the HTA will look like there. They want to understand about the data in the registry. So I suggest we put together half a day, we get the same panelists, and we bash it out. I know my audience, some of them were too shy to say anything. I would have loved to have more questions coming out, but I think I'll propose to have another round with this, and I hope my panelists will agree to join me next time. Okay.
Awesome.
Great.
Thank you.
With that, thank you very much.